Much.
All right, thank you very much. My name is Al Merati. I'm here in Seattle. I'm a professor at the University of Washington. And in terms of what perspective I have to share on this topic I believe is an audience of mostly trainees. I'm guessing mostly residents and maybe a few students, I don't know. Feel free to identify yourself or pop up, but you talk about careers in otolaryngology, head neck surgery. The perspective I have is, I think, in some ways a very tight one. It's not that broad, but on the other hand, because of the roles I've been able to serve in leadership, for example, I'm the immediate past president of our academy, of our big academy, 12,000 member academy. So even though I do what I do, which is a tight, small area of otolaryngology, I've had a chance to connect, listen, and learn, and hopefully represent successfully with the academy the senses of what's going on in the field broadly. So that's the perspective I share. I've trained and practiced in Washington State, California, at Nashville at Vanderbilt, and I lived in Kansas City, where I saw patients from both Kansas and Missouri, and then practiced for 6 years in Wisconsin. So I have some idea of what's going on broadly. So that's, I hope, a reasonable perspective to start from. So this slide's going to come up a little bit later. This is me here hiking with my two kids somewhere in Oregon. I can't remember where, but and this is me with my kids at Crater Lake a couple years ago, also in Oregon, I think on the same trip. But this stuff comes up when we talk about careers, and I think it's important to understand that we're surrounded by people who are compelling, interesting, annoying, all these things in our that energize, electrify us in our professional decision making. And it's a bit of a cartoonish thing for me to say, but there is some truth to it when I say, really, every yes at work is some sort of a no at home. I'm not here to think through your personal decisions. You're all, more grown up probably than I'll ever be. But I think that's important to think about. And I'll come back to this a little bit later, because all the stuff we talk about, how do we choose and all that, I think will be important. I am happy, as I said, to see questions and see if I can focus on that as well. I want to be responsive. I don't know quite where to aim this, but I'm gonna get going, and I'm also I'm willing, if I'm veering off in a direction that's not that helpful, please let me know. So 1978, the Who's last album from their original foursome before Keith Moon died, is one thing I think that'll be a good starting point for everyone in the early part of their career. Now, you're already massively differentiated. You've already you're into medical school, you're into otolaryngology residency, the majority of you. But then the part of you that's different, right? If you're all in one physical room, what makes us different? We have so many diverse backgrounds, diverse desires. And I think getting to know yourself, I say this to myself at 54, and I think we probably say it to ourselves at 24, but probably all the decisions that you'll make will be important to have a very good idea of just who you are and what matters to you. And these things, they don't have to be one thing or another. Obviously, it's up to you. It's your life. But I think that'll be important in making good decisions. So I want to frame this less as a litany of, this specialty is like this specialty is like this is what you do if you haven't updated your Adobe. There we are. But less as a litany of, rhinologists are like this, or don't do a fellowship. I mean, I'm happy to talk about all that. But I think I'd like to suggest that we frame it more broadly. If this mirrors or duplicates something you've just heard about, I'm sorry. I did look around and I didn't see something quite like this. I enjoyed Dr. Fritz's talk about the CVs and how to do that. So who am I? I mean, dear God, I never thought I was going to be the president of the academy. I mean, I'm a guy with a big ego, but that's for like big famous people, and it never occurred to me. So I would say, even though you think you know who you are, understanding what drives you and turns you on and rewards you, is important. So like I said, I never thought I would end up in that situation, but so it was a little hard to predict. For folks, and I don't know, I mean, but I say this to my associate professors, my assistant professors, my fellows, our students, residents, all the wonderful people I get to work with. So I challenge you, if you haven't already done this, to literally write out your mission. I mean, it's as an exercise, what is it that you're here for in your mind? And I can't say it should be professional, exclusive, or personal. These things are completely related for most of us. But I think it's an important task. It doesn't have to be, chiseled into stone, but the exercise of thinking to yourself, who am I? What is it I'm trying to get done here? What is it that matters to me? Paragraph, whatever. If you want to frame it as the second line, who are you and what do you want your life to look like in the future? This is not based, I mean, I have no illusion that we can control these things, but I think for most of us, if you have this written down, you're probably going to make better choices in the day-to-day things that approach you, the opportunities that come to you. We'll talk a little bit more about that. So if you leave here with anything today, and probably some other grumpy dinosaur like me has said this, but I do encourage you to do that. And in all seriousness, I'm not anyone special in that regard, but there are people around each of you. But if you want somebody else to look at it and help shape or refine, to understand your own thoughts, I'm willing to do that. And I know each of you have folks in your institution that do that. Interesting, a point about that. There's some advantage to having people outside of your closest circle to be a commenter, a coach, or whatever. My wife is actually a veteran school teacher. She stopped doing in classroom teaching years ago, actually when our first child was born, and now has gotten back into second career as a career coach. And it never occurred to me that people needed this, right? That's how, and I think, because I always thought, geez, don't we always have people around us? I've got my mentors and advisors and things like that, but not everyone has that. And number two, the people around you, they care, they're sincerely interested, but having outside folks who don't have any investment in your career has some advantage in providing that advice. I always wanted to be, for myself, I always wanted to be what I call the essential number two. I never thought, that I wanted to, I never thought I wanted to be a department chair. I knew I was interested in academics for lots of other reasons. It's a nice life for me. It's not for everybody. But I always want to be the essential number two. I want to be someone who had their own little fiefdom or kingdom, had a big clinic with lots of people around, and I didn't necessarily want to be in charge of a department. I'm actually kind of interested in it now, but I never thought I wanted to do that. I wanted to be, God, when I saw Jim Netterville do clinic, I thought, God, this is what I want to do for a living, or there's examples like this all over in the past. So that's what was my idea, what my vision for myself was, and it's important to understand how we get there. Some of you are maybe familiar with this, but this is from a book that's over 10 years old now that I found very helpful. It's not unique, I think, but this is from an author, Simon Sinek, who really boiled down. This is ostensibly it's really a business book. I think in a lot of ways it's about how companies and people have missions and how leaders function in those groups. That we really focus on the why, and this gets back to that slide. Who are you? When we make career decisions, I think it's important to understand the center of the circle very well. I think it's very important to understand this. It doesn't always have to be the same. This isn't. It's not. It can change, but in any given moment, understanding this. So, how would I put it? So, the what is in this context is who we are. Is the what? We're otolaryngologists. We do otolaryngology for a living. Within our professional worlds. The how we do it, some of us focus on. I express it through investigation. I express it through community outreach. I express it through a ferocious dedication to the advancement of clinical allergy. These are the ways I do these things. The what, from the outside, this is what we look like, and how we do it, the mechanisms, the day-to-days. But I think for a lot of us, understanding the why is really important. For me, I wanted, medicine's been it's a great blessing, and we're treated well by society. We get paid, people are nice to us. It is, all those things mattered to me, I confess. And that was important to me. I wanted to do something that, again, this is not a prescription for you, the listener, but as a reflection of understanding, I think it was important to understand for me why I did what I did. And I think that's valuable for all of us, whether we're writing our mission or focusing on each of our decisions. why is it we do what we do? I was interested in credibility. I was interested in quality life. I was interested in connection with people. I get my energy from other people. So those are the things that matter to me. I wasn't interested in international outreach. That connection didn't mean much to me, or as a primary thing. Just for one example, I wrote a lot of papers. I'm a professor. I have 120 peer-reviewed publications, but I don't have a particularly curious bone in my body. I just knew that if I wanted to be that person that had a practice and was known and all that stuff, I knew I had to ask and answer those questions as part of my own maturation, but honestly, part of the process. So it's not a very nice way to describe that aspect of my career, but that was something that I learned over the years, what the things that drove me. For each of us, what power do you have? I mean, when we're confronted with career decisions, and we're going to talk about specifics within otolaryngology soon, I'm sorry. The real answers obviously are yes and no. When you ask, hey, Al, can you see this patient? Or, hey, Dr. X, what about giving that talk in Paducah? What about, would you like to be on this research paper? Would you like to come do this volunteer thing? Would you like to be on this society? Really the yes and the no are important. Clearly the power in clinical medicine is yes. And again, what is it in that yes? I would encourage everyone to run this through their mind, have that mission, their own personal mission in their head, those 2 or 3 lines about what I'm up to over the long run. When you make these short run decisions, every little thing, am I seeing that consult or not? Well, of course you are. But why are you seeing it, right? This is my job and I want to do a good job and this, that, and the other. But and bigger as small and medium-sized decisions, answering this question and think to yourself, does this go towards my mission or not? So there's a duty part of it, absolutely. But there are things that don't always fit under duty that getting this question right is important. I've found within otolaryngology, not unique to otolaryngology, within otolaryngology, one thing that's distinct is really the people who are very good at saying no and maintaining their credibility as a reliable, useful partner because of their caution with their own time. So, people say no. I found this particularly in our investigators, our clinician scientists. I've found that they're the ones who are more careful with their time, the successful ones, and they don't end up doing 6 projects that suck. They do 3 projects that are successful, for example. So when you are faced with the discussions, am I going to be a co-author in this paper? Do I really want to write that book chapter, right? I think these are the things that are important for all of us. And getting that yes, no. Many of you know this amazing person that I'm circling here. This is Gail Woodson, who her and I were together briefly in San Diego when I was a resident. I was the first year resident. She was faculty associate professor before she moved on to Memphis and then Florida. She taught me the VDE ratio. Now, I don't mean to make it sound crass. She presents it in a very elegant, thoughtful way, but it's the visibility to effort ratio when we're doing things in our career. This is beyond sort of day-to-day patient care, but in terms of the other things that we are building with in training, in an early career in particular, is what is the visibility to effort ratio? Things that are lots of work and don't get you much external notice, to be frank, while you're building reputation building career, are things I would avoid, or be judicious about them. Don't have 10 book chapters that no one's going to see that don't really count. For example, for those of us who are interested in the academic and the scholarship part more, those things are not that great. Do not overburden yourself. Giving a mini seminar at the academy, with 300 people that takes a couple hours to organize and be thoughtful. I mean, that's a great visibility effort ratio. You can't make this career on, flash. You have to have substance. But being shrewd about what is it you're getting out of each of the things you do. The nuance also has to do, in my opinion, in my experience, has to do with the people, understanding the mindset of the people who are asking you to do things. There are people who clearly will be good sponsors for you. They will identify opportunities for you and put you out there. And I would say predominantly people mean well. And even when they're not doing you a favor, when they're asking you to do stuff, they're not trying to do you disservice. They're offering opportunity, but their motivations, while they shouldn't be in question, they should be, for the most part, they should be understood. People like putting other people forward for things. It makes us proud. I mean, this is, part of the thing that I enjoy every day now that I'm in those roles is getting folks connected into things. So when you're faced with decisions about, do I do this action? Do I do this action? Do I do that rotation? Do I do this clerkship? Do I do for the students? Do I pursue this fellowship or that fellowship? I think understanding these things will be important. Understanding yourself and understanding the motivations of the people around you and what they're there for. The motivations are good, but there's a reason why folks, for example, within my world in academic medicine and academic otolaryngology, there's a reason why everyone, pumps academic otolaryngology during their interviews. We happen to have a very academic training program with 1 or 2 years of research for every resident, NIH funded, and that's who we are. But it's not for everybody. It's not good or bad. It's just that's what we're up to. And understanding the motivation when people talk to you during your residency interviews or their fellowship interviews or your job interviews, well, what papers you're going to write, what scholarship you're going to do. That's because that's who they are, and they like it, and they want you to not necessarily be like them, but they're interested in people who want to pull on their same rope. They want people who will fulfill some of their personal needs for legacy. I mean, I have one fellow a year. It matters to me whether he or she succeeds for their own drive into the destination, but it also matters to me like, geez, hey, there's my fellow up there giving a talk. That makes me proud. That's good for my ego. So understanding the motivations of the people around you is very important. You're all thoughtful grown-ups, but I'm sorry if this is kind of simple-minded, but I think being candid about understanding that the ideas that people around is probably important as we make our career decisions. Being around people that are talented has been really good. I mean, I personally trained with some very, very amazing people. I know not everyone on the talk is from KU, but I was looking at your roster of folks I've got to know here and there throughout the academy and lectures over the year. You're surrounded by amazing people. And I think identifying people who are positive, who want to be with you, who want to help you, I think is really important. So I really encourage that. I want to shift gears to some more specific things. I don't see any questions in the Q&A. And I don't know if there's any direction you'd like to give me other than to continue, I'll certainly do that. So when we look forward into otolaryngology, for years, understandably, folks face this kind of cartoonish distinction between the academic otolaryngology and private practice. And it just isn't the same. Those things exist. I mean, those are the big characters, those are in the plots. Clearly, the majority of otolaryngology in the world, in the United States, is done by our colleagues in otolaryngology private practices. But more and more of our folks, your recent graduates, some of you on the line already are beginning more attracted to an employed model. These are folks who run their own practices, own their own businesses, things like that. They don't run their own practice, don't run their business. They're hired by Kaiser, or they're hired by, or again, a university, or they're in a bigger group with different leadership models, as opposed to self-employed, which is more the traditional private practice. But there's so many distinctions, and I think a better way to look in the future, rather than having this black and white difference between these two worlds, because there's so much overlap. There's so many folks in private practice doing scholarly work. There's so many folks in academics who have predominantly clinical or nearly completely clinical activity. They do substantial teaching. I think as you think about the future, I wouldn't let people just tell you these are the two paths. I think, when you're getting a job, you should think about, am I interested in being employed or self-employed? What's the size of my practice? That's one of the bigger distinctions. There's elements, the advantages, disadvantages that come with each of these. Am I in a small practice or a big practice? And the setting, of course. And then am I substantially involved in training or not? It's not, again, not a good or bad thing, but I think those are some of the distinctions. If that is part of your passion, if that's part of your why you wake up and do things, I'd investigate that. There are lots of people who are self-employed, who are in a small or medium practice, depending on what city, and they're involved in training. It may be otolaryngology residents, it may be other folks in healthcare or students and things like that. So I think understand yourself and understand what is it that appeals to you. Up until, and it took, gosh, how long did it take us to get to the word COVID? 20 minutes. Up until COVID, I think there was a very healthy enrichment and trend towards away from this push towards subspecialization and and folks in the employed model, be they academics or academic satellites, that we were seeing more forces, tilt our graduates back towards private practice a little bit, or at least slowing down the trend. But I think my guess is now over the next few years, especially in the the post-surge pre-vaccine year is going to be a little harder to figure out for careers. But I was a trainee during COVID decisions. I do sense, I don't know this, I haven't really talked that much to our trainees outside of our institution, but I do sense there's going to be an attraction early on to pursue a more employed model because some of the inherent risks and unknowns related to the self-employed model. I could be wrong about that, but I think those are the things to think about. So my point is I wouldn't let folks tell you there's two paths. There really is so many paths, and these are the distinguishers, I think, for most of us as we make our decisions. Who are you? What is it that makes you happy? What is it you think you can control, right? I mean, that's the illusion, but then what things you want to do. Now, why do people want to hire you? Why should anybody care? I mean, when, we just hired our 5th laryngologist. Is it because the institution has a passion for the mucosal wave? Well, no. I mean, they like taking care of patients. They like the fact we make money for them. They like the fact we're pursuing academic mission and training at the same time. Can we pull it off without losing money? Can we pull it off and make money? Oh, that's fine. I think understanding why people want to hire you is important, whether you're in those employed or self-employed models, and what the size of your practice. Is there a need? Is there just we just need you? You're a great otolaryngologist. We need you to come help us take care of otolaryngology. We need one more person for call. We are backlogged. The community demands it. The multi-specialty practice doesn't like the fact we're 6 weeks to get a new appointment with our 2 otolaryngologists. We need a third. So understanding that is important. What role would you be fitting in when you're thinking about this? Now, whether or not you're sitting and listening, oh, geez, I'm just figuring out if I want to do, general comprehensive otolaryngology or do a fellowship. Well, these are the things that the people hiring you that's going to be on their mind, and I think will be important to understand what the motivation is. Are they part of the ongoing trend of subspecialization? This pathway that we've been on. I'm a believer. I think subspecialty care is excellent and important part of the otolaryngology family altogether. I think we take great care of patients as subspecialists, but we absolutely all need each other. We don't need, a country full of laryngologists. We need a number of them. So is there a need? Is there an ongoing attraction to subspecialization? Folks commonly, and I'm sorry to our colleagues out there, one of the most common things that happen in group practices, they think, well, geez, I don't want to do ears. And we need somebody to do all the ears. I don't like doing ears. So they hire an otologist or they hire a rhinologist. Those are two of the more common hires. But, if you go to any practice, 5-person practice in a suburb across the country, they're hiring fellowship trained folks as more and more of our graduates do that. So what is it that's in it for them? Why are they picking you? Understanding why they're doing that is important. You have to understand what you bring to practice, and I said what's in it for them. So I jokingly, very ham-handedly changed this from who are you to who are they, understanding not just their psychology, but when you're making your first few career moves, understanding what's on their mind is important. They're going to tell you that they're not there to, durable, healthy partnership is not going to be predicated on them misleading you. But I do say it happens. Sometimes I hear a few bad stories, misleading, unawesome contracts, things like that. But generally it's people think they want something, people think they're offering something, and it's just the communication just isn't there. But who are they is important. I think understanding the team vibe in the group you're hiring with. Some of you will be hired by an individual, basically. That is less common, but is meaning that you're one person joining another person in partnership. Absolutely important part of our field, but not as common as it used to be. But understanding them is important, right? So I like this quote also from Simon Sinek, a team is not a group of people working together. That's something you can see from the outside, right? It's not a group of people working together. It's a group of people who trust each other. I think that's important. Get your sense of them. Are they, not that they're getting along. I mean, there are people who I trust who I don't get along with all the time. But I think understanding them during your process, whether it's a residency choice, whether it's a fellowship choice, if you're heading down that path, and certainly for any employment choice, understanding what their approach and what their team vibe, whether it's from the leadership, from the folks in the group in general. I think understanding that's important. This is from a guy named David Logan. Gosh darn it, I know it's Logan. Talking about tribal culture. I find this amazing. I am guilty of all the bad on here. He describes 5 groups of 5 stages of tribal culture. And I find myself in my worst moments, and there are plenty of them, that I find myself in stage 3, right? I'm not a stage 1, stage 2 guy. These are folks in bad situations, either on the inside, the outside, or both. Everything's bad, everything sucks, and you'll run into those people. You go into a big group practice and someone in the group is complaining about all these things. Could be real. I mean, probably real, probably an element to it. But also understand the general tribal culture there in the team, whether it's you're thinking about yourself, the people around you in this moment, my residency mates, my department, but also as you're approaching your careers, what is it that you're exuding? I mean, sincerely, what's coming out of you naturally, and then what is it that the team you're approaching, considering joining? There's the stage 2. I don't see a lot of this. We do hear this. This is stage 3, super common. This is the we're great and those guys suck. I have definitely done this. I don't have to go very far back in time to thinking, all those, whatever, pathology is a bunch of idiots, or I can't believe they suck at this, or, I've done this. I'm guessing most of the people on this line have found themselves saying this over the years. I do try to stay in stage 4. Naturally, I try to. Then, the grown-up part of me tries to stay in there. I wish it were less effortfully, but really when we're talking about groups and teams, just having our own pride in ourselves and making sure that, we're collectively trying to understand each other's needs that need to be fulfilled. I think about the people in my division, as the division chief, what is it? How can I make sure they're getting to their mission, right? What's their why and how they're getting there? That's an important part of leadership. When you're getting hired by somebody, does he or she think about your center, your goal? What is it that you're up to? And is there synergy there, right? Is there match? Stage 5, I know a few of these people, but I think a little hard to do. But those are ideal things where they're talking of each other and they have a very lofty goal. And those people are real. I don't personally connect with many of them, but anyway, so just understanding this about the people you're around, I think, is important. And you've heard this before, culture eats strategy for breakfast. You can have ideas and plans for your own career, but being in a place that has a culture that doesn't add up for you, it's going to be very hard to change things. It happens over time. Actually, I would not give up on cultural changes if a job is a good fit otherwise. Subspecialties do have a bit of a personality, I think, with lots of exceptions. There are some, there's an attraction that people have towards certain personalities. It's absolutely true. Historically in otolaryngology, people have said, people like this, people like that. I mean, of course, that's not 100%. But there is a sense of people. If you're going into an area, whether it's a particular job, if you're going to you're entering a subspecialty, understand, are you attracted to the people around you? Want to spend time with them on Zoom or in person or whatever? I think that's important. How do we manage the dichotomy of medical practice, right? This is a pretty striking book to pull out on an airplane. I mean, not that we fly anymore, but I got this book a while back, the recommendation from Rich Orlandi, who runs the outpatient massive, all the clinics in the University of Utah is a big job there. And it's called Patients Come Second. And I thought that's not what they told us, right? Patients come first. Well, so we're told patients are first. We know that medicine is ultimately, is so infused with the business of doing medicine that it's hard to separate these things. This idea that folks, at least in the training realm, and then particularly for those who pursue a more traditional academic path, this idea of the triple threat, folks who are spending time teaching, excellent big clinical practices, and are doing, programmatic investigation. I mean, those people are hard to find, and the environment is not ideal for all these things. We just haven't continued to commit to the creation, training, support of these folks. over the years. And money for publishing, I'll leave out that discussion, but we're presented with these challenges, and then at the same time, we're I would say, when you're looking towards this job, what is your leader doing? You as the leaders themselves, in your community as leaders in training, and then the people you'll be joining, are they taking care of you? Are they taking care of the patients? Are they taking care of both? I would argue that some of the most effective leaders, the people you're going to be hired by, or your people you are already will become, will be people who focus on the team around you. Most people in healthcare are pretty committed and pretty darn good at taking care of patients. They're not perfect. The things we all need to improve on, I need to improve on. But when you're joining a team, are they taking care of each other? Because I think left to their own capacity to pursue the things that matter to them, our colleagues, you and me, are going to take care of the patient in front of us. Being in a community where the culture, whether it's a big organization, they're taking care of the caretakers, is probably one of the most important career choices you can make. When the leadership is taking care of the providers, which I always avoided that term, but I've tried to avoid that term, but when the system is helping take care of the otolaryngologist, for example, then letting you take care of the other folks, I think that's an important group. Understanding that vibe when you get hired is probably important. So I want to move more specifically to otolaryngology and what the future looks like. Again, I know it's very dry. If you want, I can talk about Globus, my favorite subject. I was thinking the other day, here in the middle of COVID, I wanted to have a hashtag like I miss Globus, but it is a little lofty to talk about all this stuff, but I hope it's helpful. I'm sorry if it's not. What are the big questions that face us over the next 10 years, for example, as each of you, again, speaking to the trainees, as each of you leaves your core training, goes into fellowship or not, and moves on to your first career? Well, most of the big questions are not unique to otolaryngology. How am I going to get paid? How am I going to run a practice? Who are we going to see? And particularly, how does it all look in the world during and after COVID? Right now in the moment, we have doctors and patients who are scared of each other. I think understanding that's going to be important. Right now, there's so much variability nationally between, in terms of speaking about COVID and otolaryngology and the return to sort of what we do. A lot of discussion has to do with PPE and testing, and all that is real, all that's important, but there's so much national variability on the availability of those things that it's hard to make any sort of broad national recommendation. As time goes on, we're going to catch up in some of those things. But I think for the short run, a lot of our decisions are going to be based on simple things: room turnover, room flow. Like, where do people in the waiting room go? I have this waiting room for 10 practitioners seeing patients at the same time as the medical director. Where do I put them all? How do I get to that spot? How about the people in the hallway of my clinic? Coming in the door. Those are the things that are going to be in the short run. In the long run, how do we provide a safe environment in the pre-vaccine era? Again, we're expecting, frankly, that there's going to be this vaccine, but I think those are the things that are going to be important. And how we manage the room turnover, either in the OR or in the clinic, even, right? Every time I scope somebody, is that a shutdown? Is that 3 hours? Is that some wipe down and go? I don't know the answer, but I think that's going to be important. On the workforce, there is plenty of need for otolaryngology out there. Now, if you want to be, do a career of nasal tip refinement in Beverly Hills, you'll probably do great. It may be a little slower to get going, but I think there's always room at the top. But there is lots of capacity, in my opinion, based on what we understand about the workforce. There's lots of capacity for otolaryngology out there. You will not have trouble finding work as an otolaryngologist. I don't think that's going to change. We had a scare in otolaryngology that we were going to have fewer otolaryngologists. Some of you were in these matches, but we had these 2 years that we had fewer applicants, and we had to, this scary thing for lots of folks in otolaryngology, where we had 2 years where we had to, find folks during the supplementary match. I don't know if that's the right term, but people freaked out. People absolutely freaked out. And I think it's interesting why people got excited about this. There was the intellectual discussion. Was it the program specific paragraph? Was it, are we just entering into an area where people aren't as interested in? But I think the energy behind it was interesting. It's not a very popular thing to say, but I think it hurt our sense many of us, our sense of elitism. I don't think people need to be, most of us don't need to be better than other people, but it mattered something to me. You know, I walk down the hall, I'm an otolaryngologist. People know they're kind of nice, and people know they were kind of the better students in school. Again, this is all in my imagination, but I think this idea that all of a sudden we had to go get other people that weren't in our match, I think that bugged people. Is it really great for our field that we have 600 applicants for 300 spots, or whatever, 500 for 300, whatever it was? Is that great? I mean, that's a lot of disappointed people, you know. Does that mean we probably got better people? I don't know. I think so, but I think understanding why it mattered to us, who we are, and what we're sensitive, is that part of our identity? I think that's important. One of the biggest things about workforce, I think, is going to be trainee debt and what people choose. The attraction to live in certain places and do certain things for a living. It's hard to ignore the impact of our trainees, you on this call, who have $200,000, $300,000, $400,000 of debt. That is a broader question, not unique to otolaryngology, but I think that's going to be powerful. I do not know what the solution is going to be, but there's no end to that in sight. As you've seen, several of the medical schools in the country have the capacity now to offer free tuition. I don't mean too late for you guys, but you know, I think those things are happening. I do not know what the impact of COVID will be on this. Could it be that part of this had debt relief? I don't know what's going to happen, but it's unmistakably part of the landscape in terms of career decisions for many of our, I shouldn't say career decisions, sorry. It impacts professional decisions for most of our trainees. On-call matters, believe it or not. This seems like a dry subject, and residents are always taking call. You know, when you're in a two-person practice in a small town, you know, it is very hard to cover call. You have people an hour away covering for you. And when someone's approaching retirement age, they're finding it very hard to hire folks. So when you enter this agreement, you know, you should know what your call is going to be. And this is one of the great pressures. This is driving some of the decisions, you know, in terms of burnout and just work fatigue in some of our smaller communities. Not untrue for our bigger communities, but there's just more people around. So what is the role for APPs in our practice, nurse practitioners and physician assistants? Clearly, there's going to be more direct primary otolaryngology delivered by non-physicians in the future. I don't think COVID is going to have a negative impact on that, the post-COVID era, but I think that's going to happen. Satellitis, I'll skip. And then the discussion we get commonly a lot is what is the impact from ongoing subspecialization within otolaryngology head and neck surgery? It's not going back. You know, we're not, you know, I don't want to say the genie going back in the bottle, but I don't see that trend changing. We do see an interesting discussion. I'm not speaking, nor can I in any official capacity speaking on behalf of the academy. I am a senior examiner for the boards, or have been for the American board. Again, none of this is any official capacity, but I do hear this conversation about every 10 years. There's this rise in conversation of should we change otolaryngology to a shorter core comprehensive otolaryngology training, and then have separate tracks for otology or skull-base surgery, head and neck surgery, head and neck oncologic surgery, things like that. I do not sense any appetite to do that in any broad way, but there are pockets of interest in this. I don't think that's going to change anytime soon. I could be wrong, but I don't think that's going to happen. So what do we have? We have superb, organized, you know, nationally not unified. The training is similar everywhere. There's an English word for this. I'm sorry, it's escaping me, but you know, this is just a great system of residents with residency training all over, with great depth, great comprehensive care and comprehensive training. The programs are different, lots of reasons, but they're really, the standards are so good these days in particular. You know, geez Louise, I mean, back then I had a great residency program, but when I think about the supervision, good and bad, you know, it's different. You know, I didn't see faculty for every case. And that was just the way things were done. There was good and bad to it, you know, but I think it's quite different. I would say, I'm riffing a little bit here, but I think I'm one of the few dinosaurs who thinks it's harder to be a resident now than it was back then. I know it's not a very popular opinion, but I'm happy to expand on that if you like, but I think the challenges are difficult. It's tough for residents these days in lots of ways. You know, the people, the dinosaurs like me say, oh, well, we worked 105 hours a week and all that. That is true. Those are not made believe things, but it was very different and so much easier to be a resident back then in lots of ways. So anyway, just riffed a little bit there for no good reason. Sorry about that. So crab is a cure-all. I confess, one of my guilty pleasures is the show Deadliest Catch, which is still on after 3,000 years, and I still enjoy the same shots of the crab coming over the rail. I think this is important, you know, whether or not it's in your own world, in terms of within, you know, personal discussions professionally, the division department you're in, the fellowship you're going to, the practice you're signing up with. I tell you, finances impact the engagement level for folks. You know, when the crab's coming over the rail, everyone's high-fiving, and when the pots are empty, man, it gets tough quick. And understanding how people behave in these two environments is important. It's hard to see that in one engagement, right? It's hard to see that in the month or months that you're considering a fellowship, considering a job, things like that. You know, there are even this, again, I don't have this personal belief, but I do hear this from folks that some of the different remuneration amongst even our subspecialties within otolaryngology, these people get paid like this, these people get paid like this. You know, it just takes a few codes to change here and there, a system to change, and I think that'll probably could impact what people do for a living. I don't know. So I think just recognizing the impact of the finance is probably important. What does the future look like? Well, clearly the technology is going to matter. You know, here's my obligatory Star Trek slide. I mean, who knew, you know, 20 years ago we were going to have tricorders in our pockets? You know, we see that, you know, smartphone ear detection is probably going to be something people are going to get better and better. It's one of my partners, Dr. Bly, who pushed this forward, amongst other people. There's lots of people doing this work. My current fellow, Tony Law, has a very nice triage tool, which turns out it's pretty interesting during COVID time, about using voice changes on a smartphone to, and our own written code. Dr. Law did it about machine learning and trying to predict whether the patient has laryngeal mass or not. There's going to be more and more of this. So what's an otolaryngologist left to do? I mean, you're always going to need the surgery. You know, until there's medical cures for some of these things, you're going to need somebody to look, you know, or at least figure out who should be seen. This is more of a triage tool than a who needs to see an otolaryngologist tool. But there's going to be more and more of this. What, to me, this just means there's going to be a whole ton of other stuff otolaryngologists will figure out how to do to help patients. This is not a, these tools make otolaryngologists go away or less needed. In fact, you will always be the regional expert medically and surgically. I think this probably will enhance what we do. If we look at general surgeries, if I look at what general surgeons did today and what they did, you know, 20 years ago, a lot of that is now done by IR, medication, things like that. And then the general surgeons are doing amazing new things, you know, and I think otolaryngology has continued to subspecialize. I think technology will not run into things that you and I do for a living, but will enhance them in the future. Speaking of technology, some of the other things we face, I don't know if you can guess what this chart is, but my partner, JP Gilberto, who is one of the leaders in the YPS section of the Academy, made this slide for me. This is Epic. I don't know if your system has Epic or not, but there's some EHR there, I'm sure. This is the difference of our 15 or so practitioners at our clinic, the difference of time in Epic per day on average. I don't know if you can see this, but you know, some people are spending, you know, 2+ hours, and some people are spending 20 minutes. Now, this bottom person is mostly retired, but some of our busiest practitioners are in this bottom third. And I don't know if any of you can guess why. These are also the same people who have fellows and scribes, right? These are people who don't up here, right? I mean, how long is this going to be tolerated, right? This, you know, the pitchforks will be coming out, or I think I've got the Simpsons pitchforks there. You know, I think the having a fair working environment is going to be important. When people tell you, you know, I'm someone who has lots of stuff, right? I'm very spoiled. I get everything. I've been very, very lucky, but I also recognize I'm expensive, right? If I come to my department chair and say, you know, I bring in this money, and this, believe me, these conversations go on. You know, this is what I bring to the hospital. I should get paid this and all that, and that's good. You should defend your value. But you should also understand that many of our folks who are the most productive in terms of raw dollars are also very expensive. You know, we require resources. These are people with nurse practitioners who are just with them. These are folks who have scribes, not that expensive. These are folks who have, you know, other needs. So look at the cost of these things in terms of the time that people are spending in front of screens and what they're liberated to do if they're not doing that. So I think we're figuring this out over time. While I think telehealth is going to be ignited by COVID, you know, or matured by COVID, I think that's going to be important. I'm very resistant to this idea, as a Luddite maybe, but of, you know, that somehow this is a great option in the long run for patients. I don't think it's that great. I think it's incredibly useful, has a role, but I think ultimately it's going to be very difficult to do good otolaryngology without being with the patient in some safe and efficient way. So I do think it's worth pursuing, and it's going to be an element of what we do, but I don't think it's going to be a big part of what we do, in my opinion. So we talked about this a little bit. I think the last decisions, you know, that we make, I want to leave some time for questions, but understanding the workplace is important, and whether, I think one of the most important things that I've tried to listen and learn about, and this is, I'm speaking to everybody, you know, about my own personal lessons, is understanding the role of gender in otolaryngology in particular. I think this is probably the most important question professionally of our time. You know, when we look at our patients, when we look at, and a parallel conversation about underrepresented minorities in our field, whether or not that's you or you don't identify in one group or another, I think the conversation should continue. I think doing our best in otolaryngology as otolaryngologists, whether you're in a group practice of 5 or you're in a big university or whatever, having the patients, the community, the doctors, the leadership, you know, be representative of each other is almost undoubtedly a better path forward, and that is happening. If you look at the membership of the academy, the membership under 40 looks a lot more like the rest of the country than the membership over 40. And whatever forces, you know, are maturing and getting us there, you know, I think it's important to recognize these things. Making better decisions, and my wife taught me this, you know, when we think about decisions, hiring a partner, you know, choosing a resident or ranking a resident highly, I think understanding the creation of a quality environment is probably going to be paramount. And for part of your career, you're going to be in that getting in, and most of your career, you're going to be in that who do you think about, how do you shape the vision of the community around you. I think understanding the particular pressures and the history behind gender inequality is going to be important for having a successful career. I think it's going to be very difficult. Simple concepes, not unimportant, but powerful concepts, such as, you know, how many people, for example, when you're looking for a fellow, you know, or you're hiring for a job, either your new next partner, or you're, you know, right now you're in the interviewee role, generally speaking, but you're going to spend most of your career in the interviewer role. And, you know, knowing that the odds of hiring, for example, a female partner go up if you have more than one female applicant that you interview. I think those things are important to get right. And I think getting the conversation is right. Tuning out the shouting and focusing on this wonderful, amazing, willing middle who is interested in continuing the conversation, getting the words right. Sometimes I think people are, well, at least I feel like I am fearful of saying the wrong thing in the attempts to learn how to talk about this. So we talked about that. What are some of the subspecialization? Specifically, what is the problem? I think people do think there is a problem. I think there are people, from otolaryngology, I hear that there's too many subspecialists. Perversely, I hear it often from the subspecialists themselves. You know, I don't know what they're afraid of. I think there's a high-minded version of this, which I appreciate. Then there's the people literally say, well, I don't want to train the competition. You will hear that from people. Personally, if you can't outcompete your own fellow who just graduated, that's probably your fault. And good for you for training such a great fellow. So I do hear that from people. I think the high-minded, the nice version of it is important to recognize. Some of the best examples are in neurology and pediatric open airway reconstruction, right? Is it better, what's better to have 100 centers that do 5 each, or 5 centers that do 100 of these cases, right? They have these very particular index cases. Again, it's a simplified conversation, but I think that'll be important, quality control for cases. How much of what we do as fellowship trained people is really dependent on having had a fellowship? I think that's different for every field. I think understanding that, but in general, I think there's a capacity for ongoing subspecialization, and understanding that the role with comprehensive otolaryngology and these subspecialty things will be important. I do believe that more and more of our primary care otolaryngology, particularly in areas that's harder to hire otolaryngologists, will be done by APPs, supporting in partnership with our otolaryngologists everywhere. Well, otolaryngologists just do the surgery, and the APPs see the diagnostic patients, titrate the PPIs or handle the neuron or whatever. I don't know what it's going to look like, but it's probably going to be some version of that. There are some particular challenges to academic medicine as you consider your job. The traditional clinician scholar, curious person seeing patients, writing papers. The surgeon scientist, very difficult these days, but absolutely do it. It requires a team, commitment to this idea. If you think of a department within academics now, specifically, I've been trying to be broad about this, but just within academics, this team, you'd have a football team of 30 people, most of whom did about the same thing, right? Everybody did research, everybody did teaching, everybody did clinical care. In the future of those 30 people, there's going to be 3 scientists, there's going to be 3 clinician scientists, there's going to be 5 people dedicated to, the curriculum and teaching. Again, not all exclusively, but more than anybody else. And the rest of them are going to sling patients for a living in a contributory partnership way. So how do we value teaching? Fortunately, that's happening more and more. People, whether if you look at the metric of promotion, it used to be teaching was just expected. Now we write formal portfolios, we show the work we've done. I think that's important. I don't know how we literally, who gets paid for it? Where does that money come from? It's a government or a state issue for a lot of our folks. Is there a way of penciling that in? But that's where your local leadership is really going to matter. So I will stop there, just to make sure I have time for questions. I have some personal stuff to talk about if it's interesting. I guess I'll show, I'm waiting for any questions to pop up. I'll show this one slide. Remember I showed the slide of the kids in the beginning, and I said this very dramatic thing about, every yes at work is a no at home. I was, like a lot of people, I watched Breaking Bad when it came out, and not to say being an otolaryngologist is like being a meth king, but in no way, thank you for not quoting me on that, but, there was this, whatever crazy, illegal, horrific stuff the main character did, there was an element that he would say, I did this for you, my family, literally would say that. And I felt that way. Again, not as a criminal meth king, but as an otolaryngologist, I thought, gosh, these things I'm doing, I'm really doing for my family. And I realized during one of the final, I think I have a slide of it, one of the final things, when I look back on the things I've done, the yeses and nos, I do think the sacrifice that you're choosing to make of the things around you, not the sacrifice of your own personal stuff. It's your choice. For many of us, I think it's important to recognize that these are real trade-offs. This moment in the show where he confessed or recognized what was probably, of course, always true, that the reasons he did the things, he did it for himself. And it's not evil. The things he did was evil, but it's not evil that we make career decisions about ourselves. But I think recognizing how much we need to pursue those things, and that there's a price to pay for it. Every birthday missed, every gig you've given, every extra patient you've seen, and hustling to get to continue to have clinical revenue, which we're blessed to have. I think there's a price to pay for that. So anyway, those are just those things I wanted to say as I close out. I'm happy to answer any questions. I don't know if this really fit the bill or it's just kind of all over the place or lofty, but I do hope it was useful. Thank you for letting me share. I see one question. Oh, thank you very much. Thank you very kindly. And my email is available if you want to send me a question. All right. Thank you.
Thank you very much. That was great.
Thank you. Really appreciate it.
Thank you. Thank you. Bye, guys.
Bye. And Dr. Lou, hey, thank you so much.
My own Dr. Lou. Oh my gosh, that's awesome.
Can everybody hear me?
Yeah, well, that sounds good. You should be able to share your screen now.
Great. Share. Okay, how's that?
That looks good. And then maybe just wait until 11 because that's how we have it on the schedule, give people a break.
Okay, yeah, sounds good.
And then typically people participate using the chat or the Q&A, so you can watch it throughout the presentation or just look at the end. I think either one is fine.
Okay.
But looking forward to your talk. Let me know if you have any questions. I'll be kind of listening in, as will Sarah. Yeah, any
Sounds
questions?
Great. No, that sounds great. Does the screen look okay?
It looks perfect, yeah.
Okay, it's not in like presenter or anything? Okay, good.
Yeah, exactly. No, that's one problem with Zoom. All right, and thank you, Dr. Merati. There's his email. That's the chat if you want to check it out. He's saying hi to you.
Oh,
All
let's
right,
see.
well, I'm just gonna remove myself here. Let me know if you have any questions. I'll be listening in.
Sounds good.